PSM squared. I'll write the mnemonic here if it's required for you. When we read general pathology, I won't go with the mnemonic, we'll go with pure concept. But for now, yes, mnemonic helps for sure at some point of time. Okay. P, papillary lesions. S, serous lesions. M, meningioma. These are something I don't want you to forget. Actually, there are two PSM square, right? Any papillary lesions will have some homobodies. Any serous lesions will have some homobodies, which means serous cystadenocarcinoma will have some homobodies, right? Papillary carcinoma of thyroid, papillary carcinoma of breast, papillary carcinoma of kidney will have some homobodies, right? Any papillary lesion, any serous lesion, and also meningioma will have some homobodies by default, right? If you have done with this, then let's go to the second finding, because otherwise I don't feel that it's required for you to know other things. But still, sometimes very rare examiner, if they're going to ask you, they might ask you other findings as well, right? M stands for mesothelioma, the second tumor. Okay, not every mesothelioma, actually only papillary mesothelioma will have it, right? I'll put in brackets. S stands for stomatostatinoma, which is a tumor which happens in the stomatostatin secreting cells of the GIT and pancreas. Okay, again, not very common. I'll put it in brackets again. And one more, P stands for prolactinoma. Again, not all prolactinoma, only prolactinoma with a papillary finding. Okay, prolactin secreting tumor which happens in pituitary might also have some homobodies. All these are places where you have some homobody. As of now, we'll read, okay, meningioma definitely has some homobodies, right? One important finding of meningioma. Meningioma comes from meninges. So do you think it will be positive for glial marker? Yes or no? This I want you guys to answer. Will it be positive for a glial marker? No, right? So meningioma is negative for GFAP. The glial marker, what we read for your glioblastoma and oligodendroglioma. Meningioma IHC wise, it will be positive for a marker called as 𝐒𝐿MA. That's one. But I don't want you to forget this PR. Can anyone tell me what is PR? PR stand for? You might have read that in breast cancer. ER, PR, HER2/neu. What does PR stand for? ER stands for perfect, amazing. It stands for progesterone receptors. So this tumor is positive for progesterone receptors. So I'm just going to ask a random question. What do you think will happen to the size of the tumor during pregnancy? Will it become big or will it become small or same size? Pregnancy is progesterone dependent, right? Because of the progesterone receptor positivity, the tumors will grow during pregnancy. There's a very, very important clue. If you see any question which says that the size of the tumors increase during pregnancy, and if it's a CNS tumor, I have only one CNS tumor, which is meningioma, because they are progesterone receptor positive, so obviously it will become bigger in size during pregnancy, right? These are a few points with respect to meningioma. Last tumor for us is going to be schwannoma. So schwannoma origin is from, as the name says, Schwann cells, right? So what is the function of Schwann cells? You might have read that in anatomy or physiology. What's the function of Schwann cells? Schwann cells function?
Covering
of what? You're right. Myelination of central nervous system or peripheral nervous system? Of peripheral nervous system, right? They help in producing the myelin of peripheral nervous system. Central nervous system myelination is held by oligodendrocytes. That's the function of oligodendrocyte, right? So schwannoma, actually the origin, to be very specific, should be from a nerve. It should come from a nerve because they are myelinating the nerve fibers, right? So in CNS, it's cranial nerve 8 that happens in an angle called as CP angle, cerebellopontine angle. From the pons and cerebellum, the junction, the cranial nerve 8 comes. That's your nerve which is useful for hearing, right? So vestibulocochlear nerve comes from that. The most common origin of schwannoma in the brain is from cranial nerve 8, right? Now, since we know this, can anyone think of what could be the symptom? Let's open up. We have been discussing for more than 10 days, right? You should be very comfortable with me and open up things. If you make a mistake, I don't care. If the tumor is coming from 8th cranial nerve, what should be the symptom?
Hearing disturbance.
Perfect, amazing. So I'll give you two options because I'm sure you must have read ENT. I have two types of hearing disturbances. One is conductive hearing loss, other is sensory neural hearing loss.
Yeah.
Which will have this?
This will be simple.
Perfect, because
Sensory.
it's involving the nerve fibers. Conduction is problem in the ear canal or the ossicles. I'll have conductive hearing loss. Here I'll have sensory neural hearing loss. At the same time, this tumor is not just the nerve is not just for your hearing. It's vestibulocochlear. Cochlear is for hearing, vestibule is for balance and all those things, right? So patient might have tinnitus as well, right? So the tinnitus is that sensation in the ear, a ringing sensation in the ear, tinnitus, sensory neural hearing loss, classical finding. In other thing, from pons, there are multiple cranial nerves comes. They can be compressed and you can have multiple cranial nerve palsy also. Primarily these two only, fine. So when you look at the microscopy of a schwannoma, have three important findings. All three are important, right? So we have something called an Antony A, Antony B areas. These are Antony A areas and Antony B areas. And I have a structure called as Verroque body. All these three has been asked in MCQs. Please don't forget. Antony A areas, Antony B areas, and Verroque. What does Antony A and Antony B mean, right? Antony A is an area with more cells. Let's talk about more first. So A is more, then B is less cells. Or a hypercellular area and a hypocellular area is Antony A and Antony B area, right? Now, can you definitely observe that here I have less cells and more white areas? Background is more. So obviously in this area I have more cells, right? So Antony A is your hypercellular areas in the tumor. I call it Antony A, and hypocellular areas in the tumors, I call it Antony B. Okay, so these are areas in schwannoma, more cells, less cells. It's been divided. Next is this finding. Can anyone tell me how does this look like? Can I tell these nuclei here are parallel to each other? Yes, no, maybe. Are they looking more or less parallel if you look at this? If you look at this, yes, no? To some extent.
Yes, sir.
So we did read one finding in glioblastoma. If something is parallel to each other, what did we call?
Palisade.
Perfect, right? So this palisaded arrangement, the palisaded nuclei, palisaded means parallel, is nothing but your Verroque body. The palisaded nuclei of Schwann cells is called as Verroque body. The entire structure is Verroque body. This can be seen only when the cells are more. So obviously Verroque body is seen in Antony A areas. Only when the cells are more, I can have more palisaded nuclei. So obviously it will be seen in Antony areas. That's a very, very classical finding of schwannoma. One marker, if you can remember IHC, remember, otherwise ignore. It's not been asked till now. S100 is a marker for schwannoma. S for schwannoma, maybe 100. It's actually 100 name is due to the molecular weight. If you can remember in a way, it'll be great. Fine. S100 is the marker for schwannoma. One important finding, schwannoma, meningioma, both of them are actually seen in one of the classical syndromes, which is NF2. Neurofibromatosis type 2 has both increase in incidence of meningioma, the CNS tumor, just we saw, and also increase in incidence of schwannoma. Actually, one more CNS tumor, it also has an increase in incidence of ependymomas of the spine. Okay, in ophthalmology, you will read optic gliomas. Again, neurofibromatosis type 2 will definitely have all these tumors increased. Okay, ependymomas of the spine, not everywhere. Spinal ependymoma will definitely be a little bit more elevated here. Fine. Okay, so these are two things what you read today. We read about meningiomas, neural based lesion, chronic headache, and gross finding, microscopy finding. We read about schwannomas as well, right? So that ends us most of the important things with respect to one CNS tumors. So what do you guys want tomorrow? Do you want me to go with scenario based questions on this, or you want me to take some other topic?
First question, sir.
We'll go with scenario based question.
Yes.
Okay. So if it's a scenario based question, I want a little bit of more proactive participation from you guys. I'll just zoom, go out of this. Just give me a second. Okay, ignore the signs. Okay, so I'll definitely put questions, but I want answers from you guys. Right? How many of you are ready to answer questions? I'll do one thing. I'll share this PDF now after the session. Just read the PDF. I'll ask questions only from the PDF. We'll do two things. One, I'll put simple one-liner MCQ, and also I'll put scenarios so that you can solve both, but I want answers. I'll ask as simple as which tumor is more increase in neurofibrinosis type 2. Let's read, let's complete, and then let's go to the next one. Path is a big, vast subject. Let's divide difficult topics one by one. Till your exam date, I'll come live every day, Monday to Friday, if possible, Saturday as well. I want to come on Saturday as well, but Saturday is a little bit chaotic. So if not at 9:45, I'll try some other time. Fine. Any doubts? Let me know. If not, I'll share the file with you guys. Be ready for a tiny, small exam. Okay. If you want to have a prize for everyone who gets all right, I'm ready to give you a prize, but I want your definitely your participation. So any doubts? Rishabh, Ritik, Sahar, Dishar, Dopamine, Saj, Siddiq, Apurva, Charan, Amar?
No, sir. No.
Okay, great, Rishabh. So what is your plan for this Monday? What did you guys do on the Saturday, Sunday? Enjoyed?
Completed half of the forensic.
Saw yesterday an India New Zealand match.
Yes, sir.
So we have hope, right? If we can defeat New Zealand with such a low score, we'll have hope, right? Hope is always good. That will help us to go to a different level, right? Amazing. So it's fine to watch the match. It's okay. But I would say it's a 50-over match. Don't waste the entire time. Last 10 overs, watch. That's a thrill. Anyway, we've gotten used to T20s, right? So watch the last 10 over or the highlights. Don't spend an entire day. I'm sure you will watch semi-finals with Australia. Hopefully, heart should not be broken. Let's see. Let's see. Travis Head should be out. That's the only goal for us, right? So hopefully you'll win that, and also you'll win your FMGE exams. Fine. See you tomorrow. I'll share the PDF to you in the group. Read the PDF. List, recollect whatever we have taught in the lectures in the past few days, 3-4 days, right? And tomorrow we'll complete CNS tumors and be ready with the next topic. I'll continue with the next topic from the next day onwards. Fine. Okay.
Okay, sir.
Thank you guys. Thank you.
Okay, sir. Thank
Have an
you.
amazing day.
Yes, sir.
Bye bye.
Next topic.
Thank you, sir.
We'll discuss
What
about
will be
next
next
topic tomorrow, Amar. Fine.
Okay.